Thank you very much for the introduction. Thank you very much, President, for inviting me to speak about our experience in XP. So as you all know that XP is one of the rare genetic condition which is resulting from mutation of gene which is encoding protein that play a critical role in DNA repair mechanism of two pathways, which when these two pathways are affected, the global genome and transcripted couple pathway, then you get XP. So we know that we have 8 types of XP ranging from XPA to XPG and variant V. But interesting that worldwide we have a ratio of 1 in 100,000 XP. But unfortunately in Tanzania, in East Africa, including Tanzania, we don't know the prevalence, the incidence, and as well the subtype which are circulating in Tanzania. We know clinically when we see that we have XP which are more affected and those who are severely affected, but we don't know really what is happening. But as we have heard already from masters of what is happening, usually in a normal person like us, when we are exposed to the UV light, there's those protein which I've been saying, XP protein A, B, C, D, and E. They are playing a critical role in identify once we are exposed to the light, we cause a lot of damage to the skin by accumulation of photoproduct, which we have seen there. But with XP, when the two pathways are defected, then the XP patient is unable to identify the lesion. And that lesion is identified by using XPC protein and XPE protein. So when that fails, then it goes to the second part that has not been identified. Then it cannot be unwinded, which is unwinded by using XP, as you can see, XPA and XPG. So it's still remaining there. So if it cannot be unwinded, then it cannot be cut by XPE and F, and then it become a problem, then it become mutated, then everything goes wrong. Because in a normal person, that process is taken care of until everything is detected, is unwinded, it's cut, it's removed, it's ligand, and everything goes normal. This is us, but with XP, that is not happening. So why did we decide to start the XP in Tanzania? Because we see a very high prevalence of XP. Currently, we have registered 159 XP in our XP outreach clinic. We see dramatic clinic outcome, whereby younger persons are getting skin cancers. They're exposed to sun. We have lack of sun protected, social exclusion. Then being in Tanzania, that we have a regional dermatology training center whereby we are able to start this with one of the leg of RDTC's research. So in 2017, through Pedro Hein Foundation, we managed to separate the XP outreach program from people living with albinism, because at the beginning we used to see a number of XP in albino outreach clinic, but it's usually seen in 6 months. So by the time when we are coming to see them another 6 months, the tumors which are inoperable. So we separated that, and we were seeing them now every 2 months. So one of the major things that we wanted to do is we wanted to include them in early XP program, so that we can take care of them by giving them brim hats, protective, sun protective, long sleeve shirt, education to the teacher in school, what kind of children are these, what protection they want, and meeting them regularly through their coordinators, peer educator from school when they detect any tumor early, to send them to hospital for proper management. So first we conducted a clinical auditing of XP in Tanzania by just seeing what are the clinical presentation of XP in Tanzania. So what we found out that the mean age of symptom of XP was 5 months. This was when they have already seen in the hospital, whereby they present with photophobia. But we never picked up that they have any problem. They were sent to eye department, nothing were detected. They were sent home, but by the age of 5, then we see changes in the skin, that they start getting poikilodema in the skin. And you can see the majority of them, they presented with photophobia, which was not picked during the birth at the labor ward because there was nothing changes in their skin. But it was interesting to see that there are some few percentage of XP who did not present with photophobia. 93% had photophobia. And this will now come to the type of XP which we later realized. XP are more exposed to sun, especially in the face, whereby you can see the lesion that I'm explaining here, the lentigo, the hypo and hyperpigmentation, the cornea is very much affected, ectropium of the eyelid, and also the lips. Usually they also present with skin cancer in the lip, which we are trying to think maybe is because of the little sun that they are coming from the soil, and they cannot really repair the DNA. So we also, during our cohort of looking the clinical presentation of XP, we realized that there is high prevalence of tumor in our XP patient. The mean age of occurring of the tumor was 3.6 years, and we had higher number of tumor per patient. As you can see, like 66.7, they had multiple tumors. That's one patient, compared to other patient who had 67%. So these are the areas which, if you can look at from the lip, from the tongue, from the head, and all over, which I've been speaking about, that they were exposed to tumors. So from there, then we went to do the determination of the type of XP that are circulating in Tanzania, whereby we took the whole exome sequence we did. We started with 156 patients, and 4 patients could not pass through the control because of contamination. Then 152 patients were sequenced, 28 were parents, 92 were patients. So we found out that we had XPC, which was majority, 68%, with homozygous mutation in a splice site of XP, which is already known in one of the islands near Tanzania, Comorian Island, that they also found the same mutation in chromosome 3, 1414, 8732. So what was striking here was to see that all these patients with XP, majority of XPC, they had the same clinical presentation, which was difficult to say why do they have the same mutation, but some they present with a different clinical presentation. So when we ran this, we did not only go to the XP gene, repair gene, so we looked at all the 220 repair genes which are there, and we came up with XPC, as I said, in chromosome 3, 14, 14, 87, 32 position, about 90% of our patients. But the clinical presentation of this patient was not the same. So we went and looked at this type of mutation, which is happening at the splice acceptor site. And the literature says that if you look at it, when it happened at the end of the chromosome, in the intro, it has different protein expression as we have seen in the beginning, that XPA and C, they're the one which also detect the lesion when they're exposed to the sun. So if they have less expression of that, then they will not be able to show the same clinical presentation. So if you can see this, we were wondering why these both patients are having the same mutation, the same chromosome, but also presenting with the different clinical phenotype. So we had to go again in August 2024 that we had to collect another specimen. We collect 46 individuals and 6 were health patients, and we ran the RNA as what we have seen in the literature. So we took clinical data again, we took blood also, just in case. We took the skin biopsy, and we separated the epidermis and dermis, and we managed to get RNA and protein. So we had the cells, we had the primal cells, and we immortalized them. We have them now. And from here, then we could prove our hypothesis that you can see here the M3, M4. These are mutation XPC in splice mutation that express very little XPC protein. And this XPC protein is the one which will give way to detect the lesion from the XP patient when he's exposed to the sun. The same thing, the XPA also was a little expressed, which also play a major role in cutting. So as you can see here, the XPC is very little expressed compared to these two patients, XPA and F, which had a little bit of amount of expression of proteins. So we really didn't find out exactly, is it environmental surrounding which is causing this? Because all the data that we retrieved from our questionnaire was from what the patient self-report. Or is it because we are under equator, we're exposed to the sun? We didn't know. So the next step, what we did was to now have a clinical score of our patients, because there are 2 scores which has been done so far, one from Japan and one from Britain. So that this will help us to correlate the phenotype and the clinical part of the XP gene. So we know that in Japan they have studied mainly XPA, and as you can see in our cohort, we mainly had XPC. But in Britain, this was more appropriate because they looked at the clinical part and the environment exposure to the sun, which was a little bit much better to develop our own score. So based on the publications score, we had a specialist, we had a clinical opinion, and we cross-validated by unsupervised PCA, a bioinformatical analysis, and we had multiple interactions to achieve best balance between clinical and bioinformatical cross-validation. So, but again, toward what we found that mainly were XPC, 90%, again, there's a question here. So this is a clinical scoring system which we had, and yeah, thank you very much.
Muchas gracias, Daudi. Vamos a ver si tenemos a final de la sesión unos minutitos para que nos queden para preguntas.